Okay, so I'm going to talk about ITP in adults and tailored approaches for adults and seniors. So if you're 65 and you want to hear the exact recipe for your ITP, you may as well fall asleep now because it just isn't like that. There's very much, as you know, you can be 60 and you can be biologically like a 40-year-old, or you can be 60 and be like an 80-year-old. So we don't really have a age guided recipe for ITP. It's a very much an individual thing, and it very much depends on other things that are going on. So what I'm going to do is just go through a few of the considerations, and rather than saying at this age this is what we use, I'm going to go through a few drugs and treatments and really where they fit into the sort of age profile. So when we think about ITP, the factors we consider, we look at, obviously, platelet count. We always say to people, don't focus solely on your platelet count, but, ultimately, people do, and we do, and it is a sort of, it's the marker for how things are going in general. So platelet count, obviously, is one thing. Age is definitely another factor in terms of deciding whether to treat, and I'll show you a graph about that in a moment. Lifestyle is an incredibly important issue, whether people have a sedentary lifestyle or, for example, a few of my patients have been professional sportsmen who've played for Australia. And, they were certainly not able to participate in their careers with the platelet count they had when they first came. Fortunately, all those people, I won't name any of them, but they've all done extremely well in terms of their ITP and their sporting careers. And then comorbidities. So comorbidities are those other illnesses in the background. And comorbidities tend to be something that you kind of accumulate as you get older. And there's a score, it's called a Hasbled score. It's a score that predicts bleeding risk. It isn't designed for ITP, let me say that now. It's actually designed for an abnormal heart rhythm called atrial fibrillation, where people get put on blood thinning medication to prevent, or rather to reduce the risk of stroke. But if you put someone on a blood thinning medication, as well as reducing the risk of clots, you can increase the risk of bleeding. So it's a score that's used to balance the risk of bleeding versus not clotting. But it is a useful guide to the general sort of things that can increase bleeding. So while it isn't an ITP guide specifically, these are the sorts of things that if you had ITP and one of these conditions in the background, it would very much be something that might increase your risk of bleeding. So things like high blood pressure, kidney disease, liver disease, if you've had a stroke in the past, history of major bleeding, obviously. If you're on an anticoagulant like warfarin and you're very unstable, that increases your risk of bleeding. If you're over 65, if you're on aspirin, clopidogrel, or non-steroidal anti-inflammatory drugs like Brufen, Voltaren, and so on, or if you drink more than 8 standard drinks a week. A lot of you may think, gee, that isn't much. That's kind of like probably 5 drinks a week. But statistically, this is a level of drinking that does increase your risk of bleeding. So these are the sorts of things that we think about. So first of all, platelet count. So this is a graph that's very commonly projected at ITP meetings. This gives a risk of bleeding in relation to the platelet count. So what we generally, as you see, people bleed in daily life. People bleed with totally normal platelet counts. So you do see the occasional bleed. This is a grade 1 bleed, which is a very minor bleed, following a sort of an injury. But what we see here is really what's called an exponential risk once the platelet count goes to below around 30. And this is very much the data that has led us to believe that people with a platelet count less than 30 should really be the ones that get treated. And if the platelet count is above 30, well, you'll see some sort of minor bleeds with trauma, which means with a sort of an injury. You don't get much in the way of serious bleeding with a higher platelet count. So less than 30 is really where things start to take off. The other major determinant is age. So this is the risk of serious and fatal bleeding, so fatal bleeding in the brown bars and serious bleeding which didn't result in death in the red bars. So as you can see, again, a marked increase in bleeding when people are over 60. Below 40, the risk of serious bleeding is much less. Not nothing, but much less. And then finally, just going to show you a bit about the age distribution of ITP. So this This is basically the age and sex of people diagnosed with ITP. So as I'm sure most of you are aware, in the younger age group, women who are in the blue bars exceed the diagnosis rate of men by around about twice. So young women are twice as frequently diagnosed as young men, but then when you get to the older age group, older men are slightly more commonly diagnosed than older women. So again, you might be surprised to hear that the most frequently age for diagnosis of ITP is actually in the elderly, above sort of 75. So again, you kind of think of it as a younger person's disease a lot of the time, but the rate does take off in older people. So when we look at treating ITP, what are the situations that we come across that, where people need treatment? So obviously, there's the newly diagnosed patient who's just had a blood test, sometimes for no particular reason, other times because they've got petechiae or bruising. So the newly diagnosed patient who's just been diagnosed, and we tend to treat people with a platelet count below 30 in the newly diagnosed group. And then there's patients with chronic ITP, which is defined as ITP that's been diagnosed a year or more before, and whether they need ongoing treatment to keep a platelet count at a safe level. And what is a safe level? That's almost a topic for another talk. But a safe level, again, very much depends on the individual. Like I said, professional sportsmen, a safe level would be a higher platelet count than someone who's relatively inactive. And the hardest group to treat, I always find, is patients who have relapsing remitting ITP. So I've got a couple of patients who'll be going along absolutely fine on no treatment. Suddenly, will have a tremendous drop in their platelet count. It can be following an infection or a vaccination, but often it's just not following anything in particular. And they'll call me up and say, look, I've just started bruising. I've been to have a blood test. I hope you've seen it. My answer is usually yes, but sometimes no, because it's come in and it hasn't got to me yet. But, they'll just drop precipitously. And then you have to treat them, get it up, and then it's a question of when you can pull the treatment off again, because you kind of know they don't need ongoing long-term treatment. And they're the ones that's difficult because they're unpredictable. These patients, the chronic ITP requiring maintenance are kind of easy because you just need continuous treatment. The top group, the newly diagnosed, we've very much got a bit of a recipe for them. But the people with relapsing remitting, it's hard. You have to sort of go along and see if there's a pattern over time. And then finally, there are people with ITP, platelet count maybe sort of 30 to 40. So in general day-to-day life, they don't really have too many problems, despite really quite a low platelet count. But then they may need surgery or dental extraction or something like that, where it's desirable to have a higher platelet count. And again, this is relatively easy to manage. So when we think about age and sex, neither age nor sex specifically determine treatment choices, but they certainly come into the kind of consideration. So clearly, as I said, age, you tend to see people who are older with more comorbidities, and obviously in females, pregnancy or risk of pregnancies is a major consideration in young women in terms of what drugs you might use or what other treatments you might consider. So those are the things that really can have impact on treatment. So there are a whole load of ITP treatments, and this is not an exhaustive list by any means. There are lots of others, but these are probably some of the commoner treatments. And some treatments are better suited to certain people within specific age or sex brackets. And this may be because we know that people of certain age respond better than others, or it may be because there's a higher risk of side effects, or it may just simply be a matter of scheduling. That some people, younger people have more hectic lives, and having to take a drug that you take, at the same time exactly every day in relation to meals and so on may be more difficult for them. So there's a whole load of treatments listed here that I'm just going to sort of go through and tell you whether there are sort of considerations that you might use different treatments at different ages. So steroids, we tend to use most commonly prednisolone or dexamethasone for ITP. There are lots of other steroids, but these are the ones that historically we use. So we tend to use prednisolone or dex in newly diagnosed ITP, relatively higher doses for newly diagnosed people. So a milligram per kilogram, and we usually round it to the nearest 25. The reason for that is because that's the size prednisolone tablets come in. The big size is 25. You'll often see, if you see information from North America, it'll often go in increments of 20 because they don't have 25 milligram tablets, they have 20 milligrams. So they'll often say start at 80 rather than 75. It's just a matter of dosing convenience and what size the tablets come in. Dexamethasone is an alternative to prednisolone, and it's a higher dose, more potent steroid that usually is used in a pulse, that is an on and off manner of a series of bursts of treatment, whereas prednisolone tends to be started at high dose and then tapered off over a few weeks. So at later stages, steroids are also used, and for short-term use, they are used in pregnancy because they're known to be safe. We do try to avoid steroids if at all possible, and certainly high-dose steroids for long periods we try to avoid. We can use steroids temporarily to boost platelet count, and we use them in combination with other treatments to try and sort of augment the early response. We certainly try to avoid steroids in diabetics, so if you have a young insulin-dependent diabetic or an older person with type 2 diabetes, we try to use alternatives. Usually, though, if you've got someone with diabetes, it's usually easier to use prednisolone, which is a longer-term, slowly changing dose, because if you use really high-dose steroids for sort of 4 days at a time, then stop, the blood sugar's all over the place and really difficult to manage. And we generally tend to prefer prednisolone to dexamethasone in older people. Prednisolone is generally a little better tolerated. So another drug we commonly use initially and in longer term is mycophenolate. Certainly I've been using mycophenolate pretty much routinely in newly diagnosed ITP since about 2019. We use it in combination with steroids. It's often used if you want to get steroid doses down, and it can be used if you've got people on a TPRA, that is eltrombopag, romiplostim, or avatrombopag. It can be used if people have a very variable response to try and iron out, smooth out the response sometimes. Its major side effects are colitis or diarrhea, and if that develops, you just have to stop the drug. And it is a drug that causes fetal abnormalities. So if you give it to a woman who becomes pregnant in the early stages of pregnancy, it really is a very sort of undesirable drug to use because there's a very high risk of fetal abnormalities. And then you find in older people, particularly in Queensland, which is supposedly the skin cancer capital of the world, you see worsening of skin cancers. So mycophenolate is something you tend to avoid in younger women, and it's certainly something you tend to avoid in older people who've already got skin cancers, because otherwise, you know, they'll be having little bits removed every week almost. Another drug we commonly use these days is rituximab, which is, I'm sure many of you received rituximab. It's given through a drip. It can be used in combination with steroids in newly diagnosed ITP, and it can be used in long-term ITP, where around about 25% of patients who have rituximab will have a long-term response. That is to say, they won't need any further treatment, or at least if they do, it'll be a long time down the track. So when you look at rituximab, particularly if you use it in long-term ITP or chronic ITP, the people who tend to respond best are younger people, females, people with shorter duration of ITP, and people with a lower platelet count. And also you tend to find a better response rate in people with underlying autoantibodies. Now that doesn't mean to say it never works in old men, it can do, but young female, shorter duration ITP, lower platelet count are the ones that it works most promisingly with. Another drug that's more commonly used now is dapsone. Most of the data from dapsone comes from Brazil, where it's much more commonly used than it is in Europe and certainly in Australia. There are no actual clinical trials that have been done looking at the long-term use of dapsone. It's really looking back at what's called retrospective series. That's people who've already been treated. So it's a drug that has a pretty good response rate. About 2/3 people respond. About a quarter have a complete response rate, i.e. their platelet count goes to above 100. And a lot of people, the majority, if they do respond, when you stop the drug, will continue to maintain a good platelet count. You do see some complications. People often develop a degree of anemia, and that, in fact, may be required for people to respond. So it's a useful drug. It's not limited particularly by age, so it's something you can use young, old. It doesn't really matter. A drug that most certainly, I think if I ever gave danazol to one of my female patients, I'd probably expect to have a punch in the face when I saw them next. It's basically an anabolic steroid, and so hirsutism, which means hairiness. So if you've got a female patient that wants to grow a moustache, this is a good option. But if they don't, it's probably best avoided. Increased muscularity, voice change. Yeah. Anyway, so must say I don't use a lot of dapsone. I know Phil uses a bit in his practice in men, I presume. But I don't use a lot of dapsone. But it's not routinely available in Australia anymore. You have to apply for it to be imported. So. Not one we use so often. In terms of the drugs with really good evidence of safety and good effect, the thrombopoietin receptor agonists, as I said, eltrombopag, romiplostim, avatrombopag, are really the drugs with the best information to guide their use. They're all very safe and effective. They have very few drug interactions. And if one doesn't work, you can switch to another with a good chance of response. If people have had a history of blood clots, you tend to think about using alternatives, but you can use them safely in combination with blood-thinning medications or anticoagulants if people have had a clot, and continue with these drugs quite safely. There's reasonably good data to support that. So just going through the TPRAs, romiplostim, once-weekly injection. It's really good for people who have a bit of a hectic lifestyle. They only need to be in one place at one time once a week to have the injection, if you like. It's not the sort of thing they have to take a tablet roughly the same time every day in relation to their meal times. So a lot of my tradesmen, for some reason, tend to, I always discuss the options before I start people on treatment, and they tend to like romiplostim because it's a sort of, almost like once a week you inject and then you forget for a few days, and then, next Sunday or whatever, you have another one. So there are certainly case reports of safe use in pregnancy. It's not actually recommended for use in pregnancy, but if we had to use one of the three drugs in pregnancy, romiplostim would be the one. And there's certainly data out of China supporting its safety. Eltrombopag is the oral alternative. It was one of the two original thrombopoietin receptor agonists we've had for the last decade plus. The important thing with eltrombopag is there are dietary restrictions, and its absorption is limited if you take it with things called divalent cations. What that means is things like zinc, iron, copper, supplements like that. So it's the sort of thing, if you have breakfast cereal with milk on it, you cannot take eltrombopag at that time. So you really have to schedule the eltrombopag, so you take it away from those sorts of things that block its absorption. My experience has been in older patients who are admitted to nursing home is the nursing home simply cannot get the scheduling of the medication with the meals. So I've now switched people who get admitted to nursing home to one of the other two drugs that don't have any issue with food. So it's a perfectly good drug for people who respond to it, and I've certainly had patients who've been on it long term who really get on very well with it, but it's just an important consideration that the diet is borne in mind. The newer of the three is avatrombopag, which became available, I think, just over 2 years ago. It's an oral alternative. There are no dietary restrictions and really, no particular age concerns with avatrombopag. And finally, the oldest treatment for ITP, I'm sure you're all aware of. I don't know how many people still have a spleen in the audience or who doesn't, but splenectomy, probably very uncommonly used in Australia these days. Most people can be managed with drugs, but certainly it's a good option if really all else fails, or if it's something that suits your lifestyle. So there's a whole load of reasons why removing the spleen might work. Overall, if you have your spleen removed for ITP, the initial response rate's around 90%. 6 months, a year later, around 2/3 of people will still be responding and have a long-term response to splenectomy. There are some complications. It's nearly always done laparoscopically these days, certainly for things like ITP. There is a relatively high rate of having clots in the belly at the time of surgery or just afterwards, and there's an increased risk of serious infections, not a huge risk still, but certainly a significantly increased risk of infections. And it's important for that reason that people who have splenectomy get vaccinations. And in Australia, we're lucky to have Spleen Australia Registry, which you can, if you've had your spleen removed, you should be registered with them, and they will send reminders and recommendations for the vaccines that are required to keep you as safe as you can. Tends to be avoided in young children and the elderly due to the increased risk of this overwhelming sepsis. But, certainly can be a good option. And I've had a couple of patients, in fact, professional sportsmen, who've really had this thing about drugs and sport that said, I want a drug-free treatment if I can, and this is one of the options for a drug-free treatment. So I've run through a whole load of treatments. I think I've made it clear, really, there's no particular age where we say, well, this is a recipe for you, or, if you're younger, this is a recipe for you. But there are a whole load of reasons why you might consider a drug, more likely to work in an older person than a younger person. And, it's very much a sort of a discussion. It's a recommendation we make, rather than a sort of an edict, like you must be treated this way. We will recommend treatment, and it's very much a to and fro there for a bit to work out what's actually best for you.
Yeah, you mentioned splenectomy was one of the drug-free treatments. I was curious what others there are.
Yeah, well, it depends what you define drug as. I mean, there are things like intravenous immunoglobulin. You might think that's I guess in the broadest sense of the definition, it's a drug, in that it's something you put into your body that has an effect. But it's not a drug as in mechanistically is different. So IVIG, I would say. You can also have immunoglobulin subcutaneously. That's more commonly used with people with deficiencies, but really those are the main things. There's a whole load of experimental work that's being done. So Dave Cuter always talks about boosting up your mitochondria with ultraviolet light. That's something that's still being, very much in the research phase of things, but that's something that may come to fruition down the track, which would obviously be a drug-free treatment and really quite an attractive treatment, I should think, if it's available. So those, those are the main things. Other drug-free treatments, can you think of anything, Phil?
Actually, I was talking about something.
Okay. Well, I won't preempt Phil because I don't know what he's talking about. And
can I ask, the treatments that you've discussed, are they all focused at improving platelet counts as their primary goal? And do any of them help with feelings of fatigue or other effects of ITP that people might be experiencing?
Excellent question. Look, it's certainly been my experience, and I think broader experience, that there is no treatment that specifically fixes fatigue. It's really it's kind of like what we're missing, I think, in ITP management. Certainly, there is, some people describe severity of fatigue very much mirroring platelet count. Other people, it seems to be entirely independent. I guess from a kind of mechanistic point of view, you might think that something that addresses the underlying disease biology, like if you look at the things that actually target the cells that produce the antibodies, so things like rituximab, or drugs like daratumumab, which I didn't mention here, that might block the production of antibody, maybe they will kind of dampen down the underlying autoimmune disease, and that may have a better impact on fatigue than, say, the thrombopoietin receptor agonists, which more kind of just boost the platelet count. But certainly it's not been my experience or my observation that that is the case. I would be, certainly interested in comments from you guys who received the treatment to see whether you feel there's any difference. But as far as I'm aware, and certainly from my personal experience, there's no single treatment that really results in improvement in fatigue that would make you choose one drug over another. And yeah, it's kind of one of the elusive goals in ITP. It's something that still needs a definite answer in my.
Thank you, Dr. Berg. I did see on TV, and was on the news, about a new drug that was coming out to address ITP, but it wouldn't be available until the end of this year, about December. Do you have any knowledge of that?
There are a few the drugs really that are probably at that stage of development now would be rilzabrutinib, which is what's called a BTK inhibitor. We did trials with it here in Australia. It's a drug that Sanofi is marketing, so that Sanofi people may be able to comment on the timeline of its availability, but I would think that would be the most likely thing. Efgartigimod is another drug that, again, I didn't cover it here. It's more of a sort of, because it's not available at the moment, but again, it's at a very sort of advanced stage of development. There are a whole load of drugs that are sort of in the pipeline, but, still in trials, and when a drug's still in trials, it's much longer. The pipeline's much longer. So I would imagine the most likely candidate for that would be Rilza. Yeah. And it's a drug that we've, certainly I've used. I've been extremely happy with the result, but more importantly, my patients on it have also have been extremely happy. It's been a real game changer for the patients. Technically, I think response rates around 40% are seen, but if you are one of those people that respond with chronic ITP, it's a really nice drug.
It affects platelet count?
Yeah, oh yeah, very much so. And again, there's a whole, with clinical trials in ITP now, you don't just look at platelet count. They've all got patient-reported outcomes as part of the trial, response criteria. So it's something you usually do, a bit of questionnaire regularly on your phone, for example. But that sort of data is now very much a routine part of clinical trials in ITP. It's not just platelet count.
And how do you spell that, sorry?
RILZABRUTNIB. RIL. Okay, yeah. It'll have a brand name. I actually don't know what the brand name for rilzabrutinib is. I probably should know.
I've got a question for you. Who comes up with these names?
There's a convention for naming drugs. That's why a lot of drugs these days have very common sort of. So there's NIBs, there's MABs. There's a naming convention and that's why I guess new drugs tend to have more complicated names than old drugs, for example. So you can almost sort of work out what you're dealing with from the name of the drug. You can definitely work out what class they are. I presume that the naming authority is based in the US, maybe Europe, I don't know. But we just kind of accept the names that we're given. When we first do clinical trials, they're given a clinical trial designation, which is often 2 or 3 letters, which denotes the name of the company developing them, and then sort of usually 3 numbers, which is the drug name within that company. And then, if they're going to proceed to further clinical trials and possibly developed for commercial use, then they get one of these names. So AMG 531, for example, was the name of romiplostim way back at the beginning. That was the first of the TPRAs I did a trial with. And then it became romiplostim. And the stim means, again, is a designation of the class of drug it's part of. Yeah.
All right. Thank you very much, Dr. Bird.
Okay, thanks very much.